So what I want to do is go over with you, first off, the importance of choosing the right polarity for defibrillating patients. Raj will then go through his patient case history, and then again, hopefully save some time at the end if folks have any questions. I want to start with this. It's very interesting to me as part of the evolution of practice that we almost never do defibrillation threshold testing anymore. Go back to what is some pretty ancient literature, and it's ancient because it's back when I was practicing, right? That it goes to the science of defibrillation efficacy. And so there are a whole series of studies that were done in the late 90s and early 2000s to ask the question, which polarity is better for defibrillating patients? Is it better to have an anodal polarity or cathodal polarity? And it turned out, that if you look at the data, all right, there's really a pretty small difference between the two. On average, anodal DFTs are about 2 joules lower than cathodal DFTs. And I think that's a lot of the perception in the field to this day. It doesn't really matter. And what I want to get across is it does matter. And the problem is the average conceals the important data instead of explaining it. Company's named Boston Scientific. Most of it is based in Minneapolis. So let's talk about the weather in Minnesota. All right. And the average weather in Minneapolis is 47 degrees. Not great, but not awful. That average ignores the fact that some of the hottest summers and by far some of the coldest winters I have ever experienced are in Minneapolis. And it's because the average, by definition, averages out any variation. So let's look at not what happens to the average patient, because I'd submit that no one of us are average when we want to be cared for, right? But what happens to the individual patient, all right? So this is the same study, all right? And it turns out that, honest to God, about 40% of the time, it didn't really matter for an individual patient whether you check their DFT with anodal or cathodal polarity. All right. Well, that means for the other 60%, majority of patients, it did matter. And what mattered was for 43% of patients, anodal polarity got you a better defibrillation threshold. For 17% of patients, cathodal polarity got you a better threshold, and anodal polarity was worse. And that's one of the reasons, right, that virtually all ICD manufacturers used to give you the ability to program polarity and to switch polarity if one particular defibrillation strategy was not working. So with that, I'll turn it over to Raj. And Raj, let you walk through this case.
Thank you, Dr. Stein. I appreciate that you highlight the concept of polarity, the fact that defibrillation threshold testing is remote from current practice, and 3, that when we focus on the average, we're missing the individuality for the patient. So, for me, in current practice, it's a very exciting time. There's a lot of focus on where we can put a lead for an ICD. And if we get caught up with that, we'll lose the forest for the trees in that we've kind of forgotten that the generator that we choose, what therapies are available with our generator, matter for the individual patient. So I aim to articulate a case for where the individual therapies for the patient's device were meaningful. Briefly, 82-year-old male who has a secondary prevention ICD. This is a very active individual. Despite 82, 15,000 steps a day, hiking, grandfather of two. It's the highlight of his time. So a few years prior, he received a pacemaker for sick sinus syndrome. He already had a pre-existing left bundle branch block, but he received a standard dual chamber pacer. A few years later, he survived cardiac arrest in the field, resuscitated, VF captured on his pacemaker. And so when we were evaluating him, he's progressed from sick sinus to complete heart block, 100% RV apical pacing, EF has dropped, and his coronaries are clean. So we interpreted all of this, that he developed a pacing-induced cardiomyopathy, and we elected, in terms of treatment, to upgrade him to a biventricular ICD with the intent that if we improved electrical synchrony and mechanical synchrony, we would prevent another event. We also added GDMT, and we did improve his EF to 50%. At the time of the CRT-D implant, we did a modern-day version of DFT testing. Single shock or single test to induce VF at 31 joules, and it was a rescue shock, successful. And so we programmed therapies with a margin of 10 joules above. So VF therapies were 220 with 41 joules, and VT was 180 beats per minute with 41 joules. Taking us to current, the patient, despite improvement in EF and independence, VFs again. And so this time, he's not with bystanders, he's on his own, and he collapses, and he goes through a series of therapies, and during VF, and he lives. And he's completely recovered without any issues. And it sounds so simple. The device did exactly what it was supposed to do. It rescued the patient from VF. But I think there's a lot to be extrapolated, pulled out from how this patient's resonant device rescued him. So let's look under the hood a little bit. There's a PAC, a long-short sequence that results in a possibly polymorphic ventricular arrhythmia, almost 300 beats per minute. And as contemporary programming, his first shock is an anodal polarity. Pretty standard timing, pretty standard shock impedance, fails to rescue. Shock 2, same thing, pretty standard, fails to rescue. This is going to be a little redundant and a long time in VF. Shock 3, fails to rescue. Shock 4, shock 5, failed to rescue. And here we get to shock 6, and I'll just point out at this point, certain other devices, this would be an exhaustion of therapies. 6 shocks with all contemporary programming as anodal polarity. So our patient continues to remain in VF. Shock 7, unfortunately, the same, fails to rescue. At which point, shock 8, there's automatic polarity inversion here, with the device now switching from contemporary to a opposite polarity, for just to keep nomenclature the same. And this is the only change in his 8th shock that rescues the patient. So the device did exactly what it was supposed to do. Just a summary again, this is over a minute and a half of ventricular fibrillation, and our patient survived, sees me in clinic, continues to grandfather, continues to hike, continues to live well. And so I think about the differences for this patient, what was meaningful. At 300 beats per minute, there are some differences in the ATP available for the first event. Probably not meaningful at 300 beats per minute, Dr. Stein. A second argument, there's some differences in energy delivered for the initial treatment. But while there are those differences, for our patient, the first 7 shocks and the 8th shock were the same joules delivered. So that was certainly not the difference that made an impact in rescuing our patient. And what was the automated polarity intervention that reversed from anodal to cathodal, and the patient was rescued.
I also want you to notice something, right? We are now out after the 6th shock. Notice what's happened to the patient's atrial rate, right? The patient now has profound atrial bradycardia, and that's agonal. This is a patient who is in the process of dying. And so this is a patient who would have died had that last shock not resuscitated them. And I think, again, you know, it's certainly not the case that every ICD shock equals a life saved. This is a case of a life saved. And it's a life, as you said, Raj, that would not have been saved, right, had we not flipped the polarity on that final shock. And I, you know, again, I used to tell this to my fellows all the time. You know, taking something that hasn't worked 7 times and thinking it's going to work on the 8th time is the literal definition of insanity. At some point, you've got to do something different if you really want to help this patient. And is it guaranteed that that flip is going to help the patient? No, right? But it's about the only other thing you can do differently to try for a patient like that. And so, you know, I give you sort of my takeaway here, and then, you know, Raj, would love to get yours as well. You know, the progress we have made in the field as a field is fantastic. And the fact that we no longer need to do routine defibrillation threshold testing, we don't even need to do routine defibrillation efficacy testing on patients anymore. One of the reasons for that is a trial we ran called SIMPLE, right? But I think what we've lost in that is understanding some of the deeper nuances around defibrillation. And I just worry a little bit, right, that we're not, as a field, thinking hard enough about some very subtle phenomena like this, that in this case was the literal definition between life and death. I don't know if you want to agree, disagree, give a little more nuance around that.
I agree. I admit that I succumb to this kind of current approach where we're focused on what's innovative, what's new. But what we ask of industry is not just innovative, we ask for safety. And that gets lost. And so, you know, there's a lot of narrative when I talk, when I listen to the story after 6 shocks. It's a Hail Mary, doesn't really matter. It's arbitrary. There's a theoretical risk of something being truncated, a therapy being truncated. But I'm humbled for this specific patient who saw me after this event. The only thing we can point to is the fact that the therapies existed into 8 VT therapies and that there was an automatic polarity change for him.
And let's, before I ask for questions, let's end with that. And the patient has done well since.
Absolutely.
And that's something we should just all be grateful for.